Hello, everybody. I'm very grateful to Antonio for reaching out and asking me to speak again at this meeting. The first of my two talks is entitled How to Deliver the Benefits of the MRI Pathway. Here are my disclosures. So over the next 25 minutes, we will discuss the benefits of the MRI pathway for diagnosing prostate cancer. We will discuss the appropriate selection of men for MRI and therefore for biopsy. According to their clinical priorities, we will discuss biopsy yields in men with negative and positive scan results, and we will discuss how to deal with men with indeterminate findings. I will show you how the risk of cancer can be refined by combining MRI findings with PSA density when making biopsy decisions, and we will discuss safety protocols when no significant cancer is found, but clinical suspicion remains high. And I will highlight sources of benefit variability and the strategies to control and quality assure the diagnosis process. Now, we should all be aware that there are four major benefits of the MRI pathway. The biggest benefits relate to its rule-out ability. The rule-out ability means that we can reduce the number of patients undergoing a biopsy and we can reduce the diagnoses of indolent cancers. But for some patients, you can get more accurate tumor grade and volume determinations, and you can increase the detection of clinically significant cancers, particularly in prior negative biopsy patients. And this relates, of course, to the rule-in ability of MRI. So if you look at this randomized study, where systematic biopsies and MRI biopsies were undertaken with patients with positive MRIs getting a biopsy and negative MRIs not getting a biopsy, you can see that there is a reduction in the number of insignificant cancers that are found, but there's only a slight increase in the detection of clinically significant cancers. So the major benefit is reduction in the number of insignificant cancers. And this merely confirms what we know from the Cochrane review. So you can see the MRI pathway on the right, the systematic biopsy pathway on the left. And if you do head-to-head comparisons, you can see that 33% of men can avoid a biopsy. There is a 10% difference in the detection of clinically insignificant cancers, which is lower in the MRI pathway, but there is only a small difference in the detection of clinically significant disease. What this means is that if you have an outpatient population where 3 in 10 men have clinically significant cancers, if you were to perform systematic biopsies, you would miss 111 clinically significant cancers, and all 700 men with no cancers or benign pathology would need a biopsy to confirm the absence of disease. On the other hand, if you use the MRI triage pathway, you can see that you would miss fewer cancers and only 28 men would need a biopsy to confirm the absence of cancer. In other words, 672 men without cancers would be identified without the need for a biopsy. So if you look at the PSAD score and the rate of positivity, we can see that the higher the PSAD score, the more likely it is to have clinically significant cancers. But there's another way of looking at this. If you look at the numbers, you can see that 46% of men are false positive. And indeed, if you look at the literature, between 30 and 50% of men with biopsy naive have positive scans, have negative histology or insignificant cancers, in other words, are false positives. And of course, there are other problems with the MRI pathway. There are multiple quality issues. There's a steep learning curve. The performance of radiologists working alone does not match those working in higher volume centers. about 50% of men don't get benefit from the use of contrast medium, and it is time intensive to review, report, and lesion contour for fusion biopsies. So there's a number of things that we need to do to deliver the prostate pathway. And the first one is to choose the right patient for MRI. Now, of course, there are a number of types of men who undergo a biopsy. You can see that they can be screen detected or symptomatic detected with elevated or rising PSA levels with or without an abnormal DRE. And these are the most common patients. Of course, there are other patients who undergo a biopsy. These are patients who have had a prior negative biopsy or a non-explanatory systematic biopsy. When you have PSA kinetics or clinical findings in men who are on a safety net after a prior MRI, and of course there's the programmatic use of biopsies in active surveillance patients. It's important to remember that these men differ according to their tolerance to false results. So, for example, if you have a man who is at low risks, such as in the screening setting, you want to minimize the overdiagnosis, so there is more concern about false positives. On the other hand, you can have men who have a family history, who have persistent suspicion after a prior negative biopsy or a prior negative MRI. These men are more tolerant to false positive results, and they are more likely to be tolerant of false positive results. So can we refine the selection of men who need a biopsy? Remember, the major benefit relates to the rule out or negative predictive value of MRI. Now, we have to remember that the negative predictive value of MRI is highly dependent on the prevalence of clinically significant disease. So, according to this graph, you can see a negative predictive value of more than 90%. So the prevalence in the population has to be less than 30%. If you adjusted that to 85%, you can see that we will be able to accept a prevalence of up to about 45 or even 50%, but you would get a slightly lower negative predictive value. And you can see how in these four studies, where the prevalence is 20%, 30%, and 50%, that the number of men avoiding a biopsy goes down. So you can see how the major benefit of biopsy avoidance is in those men which have a lower disease prevalence. So the people who gain most benefit from the MRI pathway in the biopsy naive setting are those patients who have a PSA less than 10 and a DRE that's negative, even men with a PSA greater than 10 with a negative DRE. And you can see the blue bars represent patients who benefit. There are some patients who benefit with a positive DRE, but there are very few patients with a raised PSA and a positive DRE that actually benefit. So here, for example, is a man who's got a DRE that's positive and a very raised PSA, and you can see that there is no point in giving this man a multi-parametric MRI because he does not benefit from the full-fledged protocol. And it is for these reasons that the PIRADS committee is recommending different protocols depending on their risk. So if you have a patient who has a likely low risk, then don't do a contrast enhanced MRI. An unenhanced MRI would suffice because there's a very low probability of clinically significant disease after a negative MRI. If you have intermediate risk, if you are at intermediate risk of getting prostate MRI, then you have the longer protocol with dynamic contrast enhancement. If you are at high risk, then contrast medium may or may not be required. But if you have a high clinical likelihood of clinically significant disease, then an unenhanced MRI will suffice in the majority of patients. Now, what do we do in terms of biopsy cause and the distribution in men who elect to undergo a biopsy. So here, for example, is a man with a slightly raised PSA, very low PSA density, and you can see this man has a PIRADS 2 study. So what would you recommend in terms of a biopsy? Would you say there's no biopsy needed? He has mild BPH. Would you consider doing a biopsy because he has an elevated PSA? Do you need to look at the guidelines, or do you not give advice on biopsies? If you were to do a biopsy in 100 of these men, you would find no cancers would be found in 75%. In other words, 3 out of 4 men with a negative MRI will have an unnecessary biopsy with all its side effects. You would also overdiagnose 18 men with indolent cancers, and so you would expose them to the long-term surveillance costs. On the other hand, you would detect about 8 men with clinically significant cancers. Another way of looking at this is to detect 1 man with clinically significant cancers in patients with a negative MRI. 12 to 13 men need to be exposed to a systematic biopsy. However, if you do not do a biopsy, then you would have 3 patients with potentially deadly cancers who will not be detected. So how do you deal with this? So to minimize the treatment delays for men with likely significant cancers after a negative MRI, risk profiling is required, including a safety net of monitoring, which we will discuss shortly. So how do you risk profile men with negative scans? A good way of doing it is to use PSA density. You can see in these negative men that you reach a threshold of 10% for biopsy only when the PSA density is greater than 0.2. If it's less than 0.15, you can see you're below the 10% threshold density. So it makes sense to biopsy negative men with a high PSA density. And in fact, this is what the current EAU guidelines also say. When an MRI is negative, i.e. PIRADS 1 and 2, and the clinical suspicion is low, e.g. PSA density less than 0.15, omit the biopsy based on shared decision-making with the patient. Let's take a man with a positive scan. So here's a 69-year-old man with a large carcinoma in the midgland extending to the apex, and a tumor at the base also. You can see a small lymph node in the left internal iliac region. So in this man with a positive scan, what sort of biopsy does he need? Systematic cause, targeted cause, systematic and targeted cause, region targeted biopsies. He has a cancer, so he doesn't need a biopsy, or do you need to look at the guidelines? Well, if you look at the guidelines say that in a biopsy-naive man with a positive MRI, combine systematic and targeted biopsies, giving it the strong recommendation. So what are the trade-offs between just doing a targeted biopsies through the index prostatic lesion and doing targeted with a systematic biopsy in men with positive scans? But if you did a targeted biopsy alone, you would detect 39 cancers, and this would increase to 44 if you performed a systematic biopsy also. So in other words, 5 additional cancers would be detected by using a combination of targeted and systematic biopsies. On the other hand, if you just did targeted biopsies, you would detect 16 indolent cancers, and that would also increase by 4 if you did targeted and systematic biopsy. So there's your balance. So the balance is that for every additional man with clinically significant cancer diagnosed, you would diagnose 1 man who would gain no clinical benefit. So why is it that the targeted biopsies are missing cancers? Well, part of it is that some cancers are just simply not visible. Other lesions are missed because the radiologist misses them. Or it could be you call it something PSAD 2 and it should be PSAD 3 or 4. In MRI positive cases, targeted errors are not uncommon. This is due to fusion methods, learning curves, biopsy methods employed. And in fact, it looks as though employing region-targeted biopsies increases the yields of clinically significant disease without affecting overdiagnosis rates. Until recently, it's been unclear how to frame these additional cores. It could be that we use fewer cores or no systematic cores for larger PSAD 5 lesions, and you need more cores for smaller lesions, for more diffuse lesions, heterogeneous lesions, anterior lesions, for example. And in fact, if you look at recent papers, they suggest that the width of the regional targeted biopsies should be about 10 millimeters for a PSAD 4 lesions. And if you have a PSAD 3 lesions, you probably need to go up to about 15 millimeters around the lesion that you observe. Whereas if you have a PSAD 5 lesion, then really within 5, as long as you are within 5 millimeters of the margin of the lesion, you are probably fine. There's been a recent meta-analysis showing that region-targeted biopsies are not different in their accuracy to targeted biopsies plus systematic biopsies for the detection of clinically significant disease. But region-targeted biopsies do use fewer biopsy cores overall and avoid contralateral biopsies. Region-targeted biopsies are also superior to targeted biopsies, particularly for smaller lesions. And in fact, if you look at the PSADS guidelines, you'll see that the recommendation is to use a targeted biopsy plus systematic biopsy to keep in line with the EAU recommendations, but focal saturation or region-targeted biopsies are a viable option. And in fact, given that this is a PSAD 5 lesion, we just performed a targeted biopsies through both of these lesions to show that this patient had Gleason 9 cancer. Next, we need to talk about dealing with indeterminate scans. Indeterminate scans are surprisingly common. And if you look at the practice-based study in a mixed population, you can see that PSAD 3 occurred in about 24% of patients, and about a quarter of these men did have clinically significant cancers. You get higher rates for inexperienced users for when you use biparametric MRI, for mixed populations, and of course for your daily practice. So what do you do about these sorts of patients? Well, the first thing to do is to undertake a radiological peer review. Look at the quality. Are you compliant with the PSAD standard? Did you give dynamic contrast enhancement? And so here's a patient with a dirty looking gland. This is a patient with a slightly hyperintense lesion here in the left peripheral zone and a dirty area around it. This was called PSAD 3. And you can see that when we gave contrast enhancement, it does enhance very briskly. And this was found to be a 4+3 cancer on a targeted biopsy. And in fact, the PSA density confirms that. So you can use the PSA density to decide who to biopsy. So if we look at PSAD 3 cases over here, you can see that if you have a PSA density of greater than 0.1, then there's more than a 10% chance of having a clinically significant cancer, and you certainly should be biopsying these men in PSAD 3 cases. Of course, AI and machine learning could also play a role. And here's an example of somebody who has a PSAD 3 abnormality. So you can see the peripheral zone of the prostate gland is a rather dirty looking prostate. At the back here, you can see a slight area of hyperintensity, maybe in this area, but it's not really very dark on the ADC map. A lot of us would call this PSAD 3. You can see the contrast enhancement doesn't really help, but when you use an AI, you can see that the AI certainly identifies a lesion in the right peripheral zone that deserves a biopsy. So you could undertake biopsying all patients with PIRADS 3, or you could biopsy none of the patients, in other words, undertake a safety monitoring, but you should certainly review a lot of these patients in the MDT. Now we've talked about safety net monitoring in PIRADS 1, 2, and 3 cases. How do you do these, and who should do these? So if you look at the NICE guidelines, you'll see that in patients in whom there is a strong suspicion of prostate cancer, who have an otherwise negative MRI, you should biopsy these men if there is a PSA density of more than 0.5. This is what we've already said. On the other hand, if there's a low suspicion, then you can discharge the patient to primary care if the level of suspicion is low, advising 6-monthly PSAs and a level of PSA at which to return. So you look over here. So here's a man who has a raised PSA. You can see that this is his MRI, and the MRI shows a large nodule of BPH. You can see a false positive lesion on the AI, and you can see his PSA density is rather low. So he doesn't get a biopsy. He gets sent to the GP and is asked to review when the PSA reaches a level of 12 nanograms per ml. And remember, there is a PSA of 6 points, about 6 at the moment. So we're saying don't come back until your PSA doubles. Is this a safe thing to do? Well, if you discharge men to clinical follow-up after a negative MRI, 2 large studies have shown that the cancer-free survival is in fact over 90% over several years. So it seems like it's a safe thing to do after a negative MRI. So if a GP is looking after lower risk patients, what is the urologist looking after? A urologist looks after a patient with PIRADS 3 with an intermediate or high PSA density who is declining a biopsy, or a patient with PIRADS 4 and 5 cases with a non-explanatory biopsy. Remember, the presence of a negative biopsy in somebody with a PIRADS 4 or 5 lesion is not prognostic of a good outcome in the longer term. So benign biopsy in patients with a high PIRADS score is a poor predictor of the detection of prostate cancer in the longer term. So these patients, so in other words, patients with positive MRIs with PIRADS 4 and 5 lesions should certainly be followed because they are very likely to develop cancers on follow-up. So why are we having such heterogeneity in the biopsy results? Now it turns out that the negative predictive value is high and has a low variability, whereas the positive predictive value has an inconstant positive predictive value with high variability. So here are multiple centers showing the negative predictive value, and you can see the negative predictive value over 10 centers is in fact quite tight in the 90s range. Whereas if you look at the positive predictive value in about 25 centers in the USA, you can see that the positive predictive value in fact varies quite a lot from anywhere between 25 and 75%. So why are these, so what explains this variability? Well, it's part of the variability is to do with patients. So for example, artifacts, their habitus, whether they're metal work or gas in their rectum, but the team working is also very impactful. In other words, how well are the imagers, the urologists and the pathologists working? What is the imaging quality like? How good are the interpretations? How good is the biopsy? How good are the pathologists at identifying clinically significant cancers? So how do we go about minimizing variations in the imaging and the imagers? Firstly, we need to quality check the imaging for technical compliance with the PSAD standard, and we need to do a quality check of the images for their ability to rule in and rule out clinically significant disease. Clearly, the education of radiologists is important, so they must attend theoretical and hands-on courses with CMEs, and the performance of radiologists should be internally and externally audited, and their participation in multidisciplinary teams is a requirement. So remember, certification legitimizes individuals to perform a certain function, whereas accreditation is for service providers, including diagnostic units and the multidisciplinary teams. Certainly, we should all be working within multidisciplinary teams because there are multiple benefits. For example, it reduces variations in diagnosis and treatment, it improves adherence to the guidelines, it improves the confidence of patients and the payers, and of course, it is integral to accreditation. Accreditation is about the process of the delivery of the product. In effect, in other words, it evaluates the effectiveness of how well the teams work. So there's a number of things that a team needs to get right to be able to effectively deliver a prostate cancer pathway. So the accreditation process requires quality assurance and quality control of the entire pathway. You need to identify and measure the impactful sources of variability. You need to control and assure the variability as far as possible through automations, and you have to assess the pathway outputs. You have to develop and train and measure the performance of all the key players with benchmarking. Of course, this is certification, and of course, the key performance indices of the diagnostic units need to be measured, including biopsy complications, turnaround times, and the relevant diagnostic metrics. So here are my 5 golden rules for the successful delivery of the MRI pathway. Number 1, choose your patients carefully. Only choose those patients who are likely to benefit from an MRI based on their likely prevalence of clinical disease. Remember to risk stratify your men with negative and indeterminate scans when making biopsy decisions, balancing risks and benefits. Remember to tailor your biopsy strategies according to the patient's clinical priority, but remember to use MRI as the roadmap to target the lesions. Accept that you will not find all clinically significant cancers immediately, so you have to have robust safety nets for men with negative MRIs and men who have positive MRIs but have no explanatory biopsies. And lastly, we need to assure the end-to-end quality of the diagnostic chain with robust, audited, multidisciplinary working. Thank you very much for listening.